Ever wish for a safe place to have conversations that need to be had? A place where you could say the things that need to be said? Well, welcome to Hope for Med. Hi, welcome back to the Hope for Med podcast. I am your host, Dr. JB, and today's featured guest is Dr. Garrett Rossi. Dr. Garrett Rossi completed his psychiatry training at Cooper University Hospital. He has published articles in peer-reviewed journals, written a textbook chapter on sports psychiatry, presented at multiple national conferences, and currently serves in a leadership position as a member of the New Jersey Psychiatric Association. Welcome, Dr. Rossi.
Thank you so much, Dr. JB, for having me. It's a real pleasure.
So first, I want to start by congratulating you on a job well done. You just finished your residency, is that correct?
Yeah, that's correct. It's been a very long journey, and psychiatry training is a total of 4 years. So it's a little bit longer than some of the other medical, specialties that people go into. But overall, it was a great experience, and I can't say enough about the training that I had.
Again, congratulations. That's a major feat and something that needs to be celebrated. So I'm sure my listener is celebrating with you. So let's go ahead and start in the beginning. So what made you decide medicine?
Yeah, it's a very long story, and I think it's important to start all the way back to when I was in grade school, because that's kind of where, and I'm not going to say the cliche things that a lot of people say, like I always knew I wanted to be a physician. I actually did not know. But I had an interest in science, and specifically at that time, I was thinking I wanted to work at NASA and maybe be an astronaut or something like that.
Mm-hmm.
So that was my initial foray into science. I always had a strong interest. The issue was I wasn't performing well as a student at that time. And this is going all the way back to early grade school, like fourth grade. So subsequently, at that point, I was evaluated by the child study team, and they determined that based on my IQ and based on some of my all the neuropsychological testing, that I had a learning disability. So being diagnosed with that learning disability so early on, it really kind of set my academic career up in a poor way, because I was already kind of identified as a person who maybe wasn't going to be a great academic performer. So things like working for NASA or being a physician were not going to be in my future. More realistic expectations had to be met at that point.
Oh, wow. And what was the learning disability you were diagnosed with?
So now these days it's changed a little bit. They specify that, I know these things because psychiatry training teaches you some of this stuff. We have to evaluate sometimes children in our child adolescent psychiatry training for things like learning disabilities. And now it's changed to like where they would specify if it's in the domain of mathematics or reading or language. So it's different. Mine was kind of like a sort of unspecified. Basically, they knew I just wasn't performing at the level I was potentially capable of, and they didn't quite understand why.
So that experience as a child, how did that affect you when you're doing your assessments on kids during your training?
Yeah, I mean, recognizing that these labels don't define you. I think that's a key point for anybody. And this is big in my field of psychiatry because people have a diagnosis and sometimes they become defined by the diagnosis. I'm depressed. I'm anxious. I have schizophrenia. It really becomes something that they feel they're incapable of transcending in any way.
Mm-hmm.
So for me, the lesson is that we're definitely all capable of overcoming some of these deficits. Sometimes it's just simple things like putting in hard work and effort, but also I think it's about finding, especially for kids, what it is that interests them and trying to hone the training and education in a way that really speaks to that person. Because I feel like in my case, that's a lot of what wasn't going on in the traditional school system. I just didn't feel like the education was speaking to me in a way that I could really understand and get behind and find some passion for. So my passion for academics came much later in life than most people.
Okay. So you continued with your schooling and then graduated, and then what happened?
Yeah, so I mean, as you could imagine, my schooling through middle school, high school age were not very good, and I wasn't really queued up to do anything spectacular. So I basically, when I graduated high school, I decided on criminal justice initially. So my plan was to become a police officer. And that seemed like a good job. It seemed like one that, again, I was capable of, I had the grades for, etc. And I started pursuing that all the way from the bottom, basically. I was in a community college program, and that basically only lasted 2 semesters before I was like, maybe college and academics are not for me. I'm going to go out and work. So that's what I ended up doing after 2 semesters of community college.
Okay. And where'd you work?
So after doing the 2 semesters of community college, I went to work for my father's construction company at the time. So he had his own business and he was doing general contracting. So I spent the better part of the next like 3 or 4 years with him doing manual labor. And I feel like that was very valuable in my medical school journey. And the reason why that experience with manual labor and construction was important was because it teaches you about hard work. It teaches you about work ethic. That is an extremely important component, I think, to doing well in medical school, is learning how to work hard, how to put in that kind of effort, how to suffer through some of the difficult things that you're going to be faced with. Because although they're different in the type of work, contracting has the physical components, where with work as a medical school, it's all mental work. It's all learning, understanding, memorization. But there's a lot of parallels and similarities, and there's a lot you can take from that experience and apply to your medical school journey.
And so you said you worked in construction for how many years?
About 3 or 4 years. In total, I think between my going back seriously to college and finishing my prerequisite courses and graduating with my bachelor's degree, I had about a 5 year gap total in my time. So during that 5 year gap total, I was either dabbling in college or working.
So you were in community college and you said, this school thing is not for me, got into construction. Then what made you decide to go back to college?
Yeah, it's a funny thing. I don't want to sound again too cliche or anything like that when I talk about it, but honestly, I always thought I was meant to do more. So that really, and I knew I had that interest, that passion for science never really left. I was always reading things and watching things, and I was always fascinated by the great physicians and scientists of our time. And so I spent my off time kind of doing that and kept an interest. And I thought I was meant for more. And I said, well, being a contractor for the rest, I watched my dad and he struggled. I mean, his business wasn't always good. He didn't always make a lot of money to support the family. So it wasn't an easy life. And I said, well, I think I could do more. And I don't think I have to do this kind of work for the rest of my life. And it really wasn't. I mean, construction was not a passion for me. It was more of a means to an end.
Mm-hmm. Okay. And so when you went back to college with that feeling like I could do more, did that make the experience of going back easier?
Yeah, a lot of that comes down to mindset. And I definitely credit not only the manual labor, but also at the time I had spent a lot of time training for like the police physical examinations. So I was doing a lot of running, I was doing a lot of weight training, I was doing other things. And I think those things also teach you a lot about, again, hard work, work ethic, being able to push through adversity. And I kind of took all those tools I had gained over those years and applied them to school. And I think that's really what kind of changed. Was my mindset was very different. I wasn't going there with no plan. I was going there with a very specific goal. And that was to be the best in every single class I entered. And I went with that mindset to really crush those courses and be mindful of the fact that I started with community college. So when I went back to community college first, and I did 2 years there for an associate's degree before transferring to a 4 year college. So I've really done like the whole non-traditional medical school pathway in a sense, because I've had experiences at the community college level, the university level, and then eventually medical school and residency.
And when you went back to school, did that diagnosis of learning disability or learning disabled, did that follow you throughout college and so on?
So when I was in community college, I did keep it at the beginning. And then when I was finishing my 2 years of community, I had to be retested and recertified for it. And basically the only accommodation that they were giving me was extra time on tests. Like I had unlimited time to take tests. I never used it in community college. And then I decided not to be retested and not to continue the diagnosis at that point because I felt like in my mind, it was very important that I do this on my own without any crutches, without any benefits. Like I wanted to really prove to myself that I was capable.
So when during this period of being in, I guess, college, did you decide on medicine?
So I think I was kind of like in, but not in, if that makes sense. I knew I wanted to do something in the sciences, and I had developed like really passion for pretty much every course I took. So I loved physics, I loved chemistry, I loved organic chemistry, which is probably odd to say for most pre-medical students because nobody loves that course. But I just love, I mean, I loved playing with the models. I loved drawing everything out on paper. It really just spoke to me. So I knew I wanted to do something in science, but I wasn't 100% sure on medicine. And I'd say one of the big reasons why I wasn't sure on medicine was because I really had no idea how to get into it beyond like doing well in my courses and like having a good MCAT score. I had like very limited understanding of what a good medical school application looked like.
Mm-hmm.
And my family, the people I was associating with, we really lacked good connections for things like observerships or like opportunities to kind of mingle with current practicing physicians so that I could get some good letters of recommendation. I just did not have any of those things. And I wasn't really sure how to go about it. And at the time, it wasn't, a lot of this information is now readily available on the internet. And there's also plenty of people that you can go to and services you can use to help coach you through that process. But at the time, that was kind of limited when I was doing this. This is going back to like maybe 2010, we're talking. So it's evolved a lot now.
Mm-hmm.
But for me, that was difficult. But I knew after having some experience with basic science research during my undergrad, I kind of knew at that point I didn't want to pursue a PhD. I didn't really want to do bench science for the rest of my life. And I wanted to work with people. And I felt like medicine was the thing I really thought spoke to me. But again, I was kind of apprehensive because I didn't know for sure how to really get started with it.
Mm-hmm. So you decided to try and you applied and what happened?
Yeah, so that's another, I mean, there's a lot of pain in this journey for sure. There's a lot of there's a lot of parts that were like really where it didn't seem like it was going to work out. And certainly applying for medical school was one of those times. Again, I really didn't understand what a good application looked like. And I also didn't understand like what to apply to. Like I never applied to any of the DO programs in the United States. That was probably a mistake. Looking back on it, I would have maybe had a better shot at some of those programs. And I applied to a very small number of schools in the Northeast, basically surrounding the New York, New Jersey, Philadelphia area. And so I probably didn't apply to enough places, but I also was lacking some of those key things that I think they look for when they're trying to make a decision on applicants. While I had the grade point average and I had the MCAT score, I didn't have those other extracurriculars that they're looking for. Things like volunteer experience and with other physicians or working as an EMT or something like that. Something that would kind of show that real true passion and interest. So with that said, ultimately it was rejection after rejection from the US schools.
But you still became a doctor. So then what happens? It sounds to me like you didn't give up after you got your rejection.
Yeah, no. Well, I mean, you might imagine it's a difficult time because you're thinking, what direction do I go now? You're faced with this like kind of situation where it's like, well, you could take another year and you could potentially try to beef up your application. So I had some thoughts. I was like, well, maybe I'll go through EMT training. Maybe I'll work with my local ambulance corps for a year. I had some other ideas. I was like, well, maybe I could meet up with maybe meet some of these other physicians and get some time in their clinic to get to know the day-to-day work and maybe get a good letter of recommendation from one of them. I was thinking like that route, but I was also saying to myself, at this point, I'm already a little bit older than maybe your traditional medical student. So I was thinking about like, how much longer do I want to delay this process?
Mm-hmm.
So ultimately, what that led me to was the idea to apply to the Caribbean schools. And in my mind, there was two Caribbean schools that I thought were reasonable to apply to that had relatively good reputations in the United States. And that was St. George's University and Ross University.
So those Caribbean schools, do they have rolling admissions or how does that work?
Yeah, it's not the same. It's definitely not the same process as what you would think with medical school in the United States. So, what ended up happening was they have a rolling admissions process. You can apply at any time. And I remember going for the interview for St. George's specifically. And I drove out to Philadelphia to meet one of their alumni who was conducting the interview. And she's a great person. I still keep in contact with her today, and she's actually doing really well as an oncologist. But it was not like what you would think a traditional interviewing process would look like for medical school. I'd meet her at her apartment in Philadelphia, and we sit down and talk for 45 minutes or so. And then she wrote her assessment on whether or not she thought I was a good candidate. And ultimately, I would say like maybe a week or so later, I had an acceptance letter saying that they had reviewed my scores, my grades, transcripts, etc., and agreed with admission to St. George's. Ross was a little different. They were a little more formal. I actually went up to a place in New Jersey where because they're affiliated with DeVry and they have a DeVry campus. And I actually met with somebody from Ross who wanted to interview. It wasn't just like an alumni, it was a more formal interview process.
Mm-hmm.
And both of those interviews went great because I think based on my scores and based on my conversation with both those individuals, they could see I probably had what it took to be a good doctor, but they knew that I was missing some of those pieces. And so it was going to be hard in the States. And both schools had offered me acceptance, and I decided to ultimately go with St. George's University.
Okay. And so how was that experience being in medical school?
I want to say that if you go into it with the mindset that somehow a place like St. George's is an easier experience or is going to be less rigorous than what you're going to find in the United States, you'd be completely wrong, and you'd be making a major error in judgment there. Because when you go there, it really is kind of like a survival of the fittest scenario.
Mm.
And it's not a knock on the university. I mean, I'm happy with the education I got, and they gave me an opportunity when nobody else would. So I can't say enough about that chance and that opportunity. But at the end of the day, there's a little bit of stuff that I think people don't understand about these Caribbean schools that's really important when you're making the decision to go to one of them. So as you might imagine, they accept a lot of people. And sometimes they accept people that maybe aren't good candidates to begin with, but they're willing to give you a chance. And I'm not saying they accept everybody with really poor scores, but they do accept a larger number of students than what you would see in a typical school in the United States. And basically, they put you to the test because everything is maintaining a certain mean weighted GPA. So if you don't maintain a certain average, you can get dropped from the program at any point. Basically, the fear of being dropped or failing out is constantly there during the time. And that's one of the things I remember most vividly, because even if you were a good student, and which I was, I did really well while I was there, I always had in the back of my mind, any one wrong move might put me in a bad position here.
Interesting. And that's not just grades. It goes beyond grades?
Well, I mean, here's sort of, like I said, when I talk with most of my colleagues that went to US schools, a lot of times like first term and sometimes even the whole first year, it's basically pass fail.
Mm-hmm.
It's not a mean weighted GPA.
Mm-hmm.
And our mean weighted GPA was, I think when I was there, was 75%. Now I've recently heard it's 85%, which is pretty tough. I mean, to maintain 85%, an overall 85 percentile, that's asking a lot for a lot of students. And that starts from day one. That starts from first term, even when you're just getting used to being on the island. And when people ask me, they go, well, weren't you so happy like being on a Caribbean island? And I was like, well, not really, because I didn't enjoy the island very much. I had a few chances to like explore and to take a few breaks after like midterms or finals, but ultimately I was there putting in work every day. And I mean, and I'm talking like anyone else would do in medical school, 10, 12-hour days at a desk in an air-conditioned room, basically, not necessarily outside on the beach or enjoying what the island really had to offer.
You said your class was larger than you would find in the US. Mm-hmm. So how large was your incoming class?
Yeah, I think mine when I was coming in was almost 1,000 students.
And how many people made it to the end?
So how many people left the island? I want to say we're somewhere in about 680 people.
Left the island?
Right, graduated the first 2 years.
Oh,
finished the first 2
graduated.
years.
I thought you meant like
Well, no.
they didn't make it, like
So,
they got
so no,
dropped.
those are the people that made it. Because I only remember that because of a statistic I saw in one of the surveys. How many people were offered the survey, the ending survey, like the survey they provide at the end of the 2 years. So that was only the first 2 years. I guess an important point here is with a place like St. George's, you go there for your first 2 years, and that's where you're doing all of like the academic lecture type of work and a little bit of clinical work, but mostly it's like being in college again, learning all of the necessary prerequisite stuff to get you ready for clinical rotations. And then when you come back for years 3 and 4, they're going to be in hospitals within the United States. And they have various affiliations that actually change pretty much every year, depending on, I would argue, probably depending mostly on money, but I don't know all the fine details, but I know they tend to have changing hospital affiliations, but they are more stable than other Caribbean medical schools, which I think is important.
Once you get past those first 2 years, are you kind of set, or is that fear of being dropped still present?
So it's less likely at that point. And the reason behind that usually is clinical spots are hard to come by. So if someone's not going to do well, the hope is that they would probably not do well during the first 2 years before they take one of those clinical spots. So a lot of times once you get to year 3 and 4, you've kind of made it, so to speak. You still have, of course, your board exams to pass, which can hang people up too. I mean, I've seen people lose out because of failures on CK or something along those lines.
Hmm. Hmm. And so you're on this beautiful island. You're not able to enjoy it. You're studying tons of hours a day. And how did that affect you in any way?
Yeah, I mean, I think that's one of the lessons I really took from that experience and I applied to my residency was that you need to keep something for yourself. So, what I mean by that is if you have a hobby or interest outside of medicine, you're going to want to at least carve out a little bit of time each week to do that. Because one of the mistakes I think I made was actually going way too hard, way too fast and then kind of by the end of the first 2 years hitting the wall a little bit.
But I can't see how you could have done it any different because of the fear that you're going to be dropped out of this Caribbean medical school when you had to have, you said
Hmm.
70, 75%.
75%, yeah, for my class. I think the other thing to be mindful of is that while is depending on how you're funding your education. So for me, like I said, I come from a blue collar background where resources were pretty limited. So I had to fund my education through student loans. Now, when you're taking student loans out for hundreds of thousands of dollars, that adds even more pressure, I think, to your desire to succeed. And unfortunately, all of these things take the pleasure out of learning because learning can be a lot of fun and enjoyable. But when you're faced with that kind of pressure, both financially and academically, it does hurt you.
Mm-hmm. Mm-hmm. And so how did that kind of pressure affect you?
I mean, I think I handled it well initially because it was new and I had a lot of energy and I was very, very motivated. So basically the mental strength that I gained over those years off and away from academics, I was able to apply very successfully to the training. However, towards the end of the second year, that's when I really started feeling the pressure because they changed the way some of the classes were structured. I personally am a independent learner and I prefer to do like the lectures virtually and learn on my own. I just am much better that way. I always have been. But they started making some of the classes mandatory to attend and there was a lot more lab time and things of that nature. And so it was kind of cutting into my traditional way of learning. And I was resisting that, which, is never a good thing. Anytime someone's resisting, you're putting additional stress and pressure on yourself because you're like, this should be different. Why isn't it different? Look how good I did in the first couple of terms. Now I'm here and it's more difficult and my grades are slipping a little bit. All those things started happening. And I think that's when I started panicking a little bit towards the end, and I think that's kind of what hurt me going into my step one as well, because I was pretty burnt out by the time I hit my step one board exam.
Mm. That's interesting. You're a medical student and you're feeling burnt out.
Yeah, exactly. It starts early, right? Burnout, I think it starts early, and a lot of these things about burnout, though, I feel like are systemic problems. And lately, what we observe as physicians is that a lot of the burden falls to you as the individual to figure out how to recharge your batteries and how to avoid feeling burnt out. But there's not enough responsibility, I feel like, on the systems for some of these things and some of the ways that not only medical school training is, but also the way medicine's practiced.
Hmm. So talk more about that. What do you mean? How could the system do better?
Yeah, I think it's the things that eat up your time. One of the things I can think about as a physician now, and having gone through my residency training that took majority of my time, was documentation. And a lot of times I was documenting with legal things in mind. I wasn't documenting with like the patient's interest in mind. I was documenting, did I hit all my points so that I'm going to be sure if there's an adverse outcome, I'm going to be covered. And that's not really, I think, the way to practice medicine. Unfortunately, I think that's one of the biggest problems we face as physicians, is always kind of worrying, like, are we documenting appropriately? Are we saying everything that needs to be said? And it's a little unrealistic because we're all still human
Hmm.
and we're going to make mistakes. We're going to have oversights. As trained as you are, you're still going to face those situations. So I think that's one place certainly that leads a lot of people to feeling just kind of burnt out from the process.
Hmm. It's true. I mean, it's been shown by research that EMRs are contributing to this burnout epidemic.
Absolutely. And I'll say I was trained in my training on, I think, three different EMRs. I used the VA system, I used Epic, and I used Cerna. And I got to say, like, people love Epic, but for me, Epic was way too busy. It was actually contributing to more, like, it has tons of great information, but it's impossible, I think, for anyone to process all of it in any kind of meaningful way. So to me, like, while people say it's a great EMR, maybe arguably the best EMR available, I did not find it that way. And I thought because it was too busy.
Hmm. So you're telling me that Epic is not the Holy Grail?
Yeah, I mean, not to, they probably want to kill me for saying these things, but it's just like, and again, this is, of course, we have to take, I'm biased. I have my own opinion
Hmm.
on things. I have to recognize my own bias here. So I'm not saying my opinion is gold here either, but just from my experience, I actually thought in many ways that was contributing to more of the difficulty with documentation than it was
Hmm.
actually helping.
Hmm.
So it's
Hmm.
a great concept in a way, provide an abundance of information so that everything is there at your fingertips. But I think it's overwhelming. And again, it all takes away from the most important thing, which is patient care.
Yes.
That's one of my biggest things, I think, is, and psychiatry is maybe one of the worst places now because they want psychiatrists to practice like family physicians. They want you to be able to understand the intricacies of the mind in 15 or 20 minutes, and that's very, very hard to do. I think
Really?
even 30 minutes is not enough time.
Really? So they've cut back on the amount of time you're able? It's not 55-minute session anymore?
So a lot of places will say something like this. They'll say, you have 30-minute follow-ups. Let's just say we're talking about follow-ups. You have 30-minute follow-ups, but we prefer you to be able to do them in 20 minutes. That will be kind of the way it's phrased to you. So it's like, yeah, we're happy. Now, I'm not doing outpatient work, so I'm largely spared of a lot of those aspects of it. I'm
Hmm.
doing inpatient work as a psychiatrist, which is definitely different. And that was one of the things that actually attracted me to inpatient work, was the fact that I wasn't responsible for these like kind of timely visits. I could structure my day how I wanted to, as long as I saw my patient load for the day.
Wow, that's very interesting. So, in 20 minutes, is this just essentially medication reconciliation? Are you supposed to be
Right.
counseling during that time period too?
Well, yeah, I mean, so that's a great point. I think one of the things you're hitting on here for sure is the aspect of therapy. And in psychiatry, we know that the most important thing, and this is probably true for all of medicine, but I know specifically the data for psychiatry shows that the therapeutic relationship, the therapeutic alliance with your patient is actually the most important aspect to them getting better, regardless of medication or therapy modality that you choose to use. So techniques are great, medications are great. They definitely work for the right patients in the right circumstances. But ultimately, it's all about that relationship. And that's the part that we're losing, these short interactions. Because, like you said, you have basically enough time to say, okay, you're on this medication. Are you having any side effects from this medication? Is this dose adequate? A quick symptom check. And that's basically it. It's a few minutes to kind of check on their symptoms, see if there's any adverse effects happening, make sure everything's stable, and move on to the next person. And it's unfortunate because, again, a lot of what we do, I think, happens in the relationship and not so much in the medication management.
So, with these changes, does the patient have somebody else in your team that they go to for therapy, like counseling, or no?
Yeah, so there are, like, in my experience in the outpatient community clinic, so I've always worked in a community setting, which is kind of important to note because that's a little different than, like, say, private practice or something along those lines. But in the community setting, they essentially employ various therapists, but I'd say we're not talking about PhD or PsyD level psychologists. We're talking about people with like maybe master's level training,
Mhm.
which is fine. But one of the things I personally ran into is if I want to refer a patient for therapy, a lot of times I would be hard pressed to find a therapist who did a specific type of therapy. So let's say I thought cognitive behavioral therapy was the right way for this patient to be treated. I would not be able to find someone who really was an expert in cognitive behavioral therapy. Basically, what I found was most people were doing some type of supportive, basically what amounts to a supportive psychotherapy, which is great. I mean, it's better than nothing, but it was difficult to find, again, experts in certain types of therapy when you thought they were appropriate for your patients.
Wow. Who knew?
It's a very challenging situation, but I can say the place where I found so much value in my fourth year of training was with my therapy patients. I mean, the connection and the bond that we had was so strong. I was distressed about letting them go in a way, even for, and that's my in psych talk here, countertransference for these patients. And to me, like, that experience, like, I learned things about those patients that I didn't know about them at all during my medication management with them.
Oh, interesting. Because you
So
didn't have
it was
time. You didn't have time to find out
right.
about it, right? You just focused on side effects and do you need a refill and etc.
Right, exactly. I mean, you're focusing on kind of the basics. And unfortunately, psychiatry kind of gets a bad rep to begin with. We have, interestingly enough, we're the only specialty that has an anti movement. There's no other medical specialty, as far as I'm aware, that has an anti movement, but there's definitely an anti psychiatry movement for sure. And I've encountered some of these individuals here and there along the way, especially if you're out in the public eye in any way.
Ah, speak more about that. What do you mean by an anti-psychiatry movement?
Yeah, so there's a large group of people, and some of this was actually the Church of Scientology had kind of promoted a lot of these ideas, but there's other groups as well. It's not just them, but they might be one of the larger groups. And basically, it's a group of individuals who feel like psychiatry has harmed them in some meaningful and appreciable way. And they'll basically come to you and say that the medications don't work at all. There's no benefit. They destroy people. All psychiatry's ever done is harm people. Now, for me, being a student of the history of psychiatry, when you look back on these things, and I think you can do this with any medical specialty, you can look back and say, like, were there some atrocities? Yes. Do we take responsibility for them? Yes, we have to. We have to take responsibility for those things that didn't go the way they were planned. But I think one thing that's lost in society today is intent. And if you do the reading, the historical reading on the field, you'll see that the intent was always good. The intent was always to help people. It didn't always work out that way. But based on the available information, based on the things that people had at these times, these were the best options that they came up with. And so I think, again, intent matters. And most of the physicians that I work with, I mean, all of the ones that I work with, honestly, are really good hearted people who I think genuinely have the patient's best interest in mind.
I wonder if part of this has to do with bringing to the surface repressed thoughts and memories that you feel like you were functioning just fine without thinking about them or remembering them. And
Mhm.
now you are remembering them through your therapy sessions and you feel like it's having a detrimental effect on your life.
Well, I mean, you're making a great point about therapy in general, and that is that it's very hard work and it's at times very painful. And you have to be prepared for that experience, unfortunately. And a lot of people aren't. And that's why I think medication became so prominent in the field in some ways is because people didn't really want to do the work. And I don't blame them because it's very hard work. I mean, I can think of some of the cases that I treated where trauma was a big part of the issues, and things like post-traumatic stress disorder were one of the primary concerns. And just having to, like you said, relive those experiences. And what I did in some of those cases was I used what's called cognitive processing therapy. And what that requires someone to do is to essentially go back and relive in vivid detail through writing, through narrative, those experiences. And so it's not for everyone. It's not for every patient. And luckily, I was able to identify some people that were very good candidates for it and who really did extremely well with that type of therapy. And it really helped them move on from those traumas. But again, during that 16 weeks of cognitive processing therapy, it was tough. I mean, it was even hard for me to listen to at times because some of these things are so devastating and so tragic.
So many questions I'd like to ask you, but let's go back a little bit back to you were finishing up your medical school and you hit this wall. And
Mhm.
how did you overcome this wall? And what do you mean by you hit the wall? Can you explain that a little bit more in detail?
Yeah, so I think hitting the wall is when you wake up in the morning and you don't feel like doing the things you need to do. I was kind of, I remember vividly even having some like nocturnal panic attacks during the end where I would wake up in the middle of the night, kind of like short of breath, like, and have to get out of bed and kind of gather myself and calm myself down to go back to sleep. So I was, and part of that was the pressure from the school, like we talked about, but part of that was my own pressure because I always wanted to be great. I always wanted to be perfect. And that is a dangerous game to get into with medicine because it's so hard to operate on that level on a day-to-day basis. You're really putting a lot of stress and pressure on yourself. So I was putting the pressure on myself too. And it was all kind of culminating. And that's the things that really stood out to me was just like a lack of motivation and drive to keep going at that point. And basically, what I did, like, I think I took like almost like a military-esque style of thinking at the time, which again probably wasn't the best choice, but I just pushed through it. I said, okay, well, you know what? You don't feel like doing it, you're gonna do it anyway. And that was how I treated it. Now, looking back on it, it probably would have been better to step away and just say, okay, you know what, this stuff isn't going anywhere. A couple days to recharge the batteries is not going to destroy your step one score or anything like that. You've been working hard. You have to remind yourself you're working hard all the time, and you have to trust a little bit in that process and have the ability to step away.
Mm-hmm. You said that when you finished medical school, you changed the way you approach things. And so, how did you approach residency that was different than when you were in medical school?
Yeah, I mean, one key point I think everybody who graduates medical school should take away from it is that once you finish the training of medical school, you feel a little bit more like you belong. When you're in medical school, you're trying to find your place, even in your clinical rotations, like where's my place within the team? But once you become a resident, that part like kind of goes away. Right now, you start to become a really valuable part of the team, someone who can actually do some things and create some benefits and provide some value to the treatment teams in general. So that part changes for you. But from my own mental perspective, I decided to pick up back on some of the hobbies and interests that I had. I decided, you know what? I need to go out with friends for those occasional dinners. I need to continue my workouts, which are very important. Being healthy and lifestyle medicine is a passion of mine. That's a whole nother topic we could talk forever about. But basically, I wanted to keep those things that mattered to me in my life, and I just made the decision to do so.
So, it was an intentional, conscientious effort to really incorporate things outside of the day to day of residency.
Absolutely, because residency can be another difficult transition for people. I feel like one of the challenges of being a trainee in medicine is that every 3 or 4 years or so, your life is abruptly changing. When you graduate your undergrad and you go to medical school, that's an abrupt change. When you finish your 4 years of training in medical school, you go to residency, that's another abrupt change. And they all require sort of different skills to navigate, and they're all like, I mean, at least for me, stressful times, because you, by the end of your 4 years of medical school, you've developed a good routine for yourself where you're comfortable and confident, and it's very easy to kind of continue that process. Then going to residency, you're kind of asked again to take on different responsibilities and play a different role, which takes some time to get used to.
Mhm. And it can feel very terrifying with each new experience because it's an unknown. You don't know what you're getting yourself into.
Mhm. One of the best things best pieces of advice I could give for any new incoming interns, I would say that you want to jump right in to seeing patients and treating patients. Get started, start seeing patients, start putting medication orders in. You want to be writing your H&Ps and progress notes. You really want to start right away. Don't take it slow. Don't be apprehensive about it. I had a great attending who, I mean, as much as he didn't do as much teaching. He gave me that autonomy that I needed to kind of develop my confidence early on. And that was key, I think, at the beginning of my residency to being successful over the course of the 4 years was I developed a confidence early on in my management of patients. And I felt like right away I could do it. And that was helpful. And that will help carry you through the rest of your training.
Hmm. And when you started medical school, did you come into it knowing you wanted to do psychiatry?
During the first 2 years, I actually thought I wanted to be a general surgeon. I was pretty sure that's what I was interested in, and I was focused on anatomy and things of that nature during my first 2 years. And my first rotation in third year was general surgery, and I absolutely hated it. I mean, some people will love it. So again, this my bias, my opinion, but I did not like it at all. I thought it wasn't a very nurturing learning environment at all. And when you're new to something, I had never tied a suture before, so I had a lot of work to do in terms of
Mm.
just getting comfortable in the operating room and getting comfortable with patients in that setting. And it was tough for me. And I didn't like it. And I said, well, all right, glad I figured this out early on. I definitely don't want to be a general surgeon anymore. And my second rotation was actually my psych, and I just loved it. And I think the thing that stood out to me about it was not only did I have a passion for the information and for the training, but I was pretty good at it right away, which was different than my other clerkships. The other clerkships, you had to work at getting good at them. This one, I just there was something natural about it. There was something that felt like home for me.
Mm. Okay. And going back to what you talked about early on when we first started talking was about labels and the effects of labels. And as a
Mhm.
psychiatrist, part of what we do in medicine in general is put labels on people. You have
Yeah.
diabetes, you have high blood pressure, or whatever, you have major depression, etc. But when we think about these labels, when we think about stigma associated with some of the psychiatric labels,
Yeah.
could we talk a little bit more about that?
Yeah, I love that because as much as we're doing our part, and I'm certainly trying from my perspective to eliminate some of the stigma surrounding psychiatric treatment and also even again for psychiatric training and for people who are interested in the field, it still exists. And it's a big part of what we have to face on a day-to-day basis is how to kind of reduce that stigma, how to help people to feel comfortable. Now, what differs between diagnosis in psychiatry, I think, and a diagnosis in other areas of medicine is because we don't understand fully the mind brain disconnect, right? We have a disconnect. There's the physical components of the brain, the neurons, the neurotransmitters. But then there's this concept called the mind that really we still have no idea what it is. So we lack those objective measures that things like emergency medicine or internal medicine have, where you're able to look at imaging, you're able to order a blood test. There's things that can lend themselves to the diagnosis that help make people feel a little more comfortable that that's exactly what's going on. If there's an arrhythmia in the heart, we have an EKG, we can identify it and we can show the patient, yeah, this is the problem. We're going to take care of it by doing X, Y, or Z. In psychiatry, we don't have that option. They have to kind of trust basically our clinical assessments based on what ultimately amounts to a cluster of symptoms, whether it's major depression and the old SIGI caps mnemonic, 2 weeks or more of those symptoms. And I think people are a little skeptical of that, number one, to begin with. And the other problem I've observed as a clinician practicing is that the diagnosis can sometimes evolve. You may initially think somebody is more of a major depressive disorder, and then it turns out that you're thinking now, no, after working with them for a year, I'm thinking this person's more on a bipolar spectrum and may not benefit from an antidepressant medication. They may actually benefit from a mood stabilizer. So I think that sort of evolving diagnosis doesn't exist as much in other areas of medicine. Again, it's more cut and dry and easier for people to understand.
And then when you apply these like psychiatric services to your colleagues in medicine, your
Mhm.
peers, and the stigma associated with that in medicine, how that label could affect credentialing.
Yeah, for sure. I think a lot of people who are physicians, and there's a lot of physicians that seek psychiatric treatment. So I don't want to make it sound like all physicians are apprehensive about seeking treatment if they need it. They do get it. I mean, the only thing I think that could maybe affect your credentialing and things of that nature would be an involuntary admission to a psychiatric hospital if you were, say, acutely suicidal and determined to be a danger to yourself, and then you were committed. Those things do follow you around. They prevent you from things like firearm ownership. They could prevent you from certain careers. So there are some things to be mindful, but the general treatment of, say, depression or anxiety or something along those lines, I think is largely a reasonable thing and shouldn't affect physicians too much. But again, there's that worry that, well, what if my colleagues find out? Will people see me differently or view me differently? And I think that that's a lot for my colleagues to kind of deal with. So there's always that stigma and worry.
Hmm. And there's the questions about have you been diagnosed with
Hmm.
psychiatric condition that is
Yeah.
on that application for renewal of your medical degree.
Yeah, that's a problem with the way that, I mean, I personally view this as no different. Like, I would view depression as no different than diabetes, like the example you kind of gave before. It's a disorder, it's a dysfunction that we believe it should be treated no differently than any other medical condition. But unfortunately, you're right, there's still this idea that's not the same. And that's what we need to work to change and still need to work on. Personally, I also think it's honestly none of their business what you're being treated for. I mean, I think your medical stuff, just like we do with like HIPAA, it's your own personal medical data, and whether or not you choose to disclose those things should really be up to you.
I agree. It's none of their business, but they ask the question still. And I know
Right.
that you
Yeah.
are very active in advocacy. Is that an area that you're focused on right now or not really?
So, one of the major areas that I focused on was this idea of a collaborative care model. And how that relates to stigma is a lot of patients in general are going to access psychiatric care through their primary care doctor first. So, what the collaborative care model does is it allows for there to be a psychiatric consultant available to the primary care doctor to precept on difficult cases or to potentially see difficult cases if they think it's beyond their scope of practice and something that they think would be better suited for a specialist. So that helps with stigma because it's very different, I think, for people to say, like, oh, I'm going to see my doctor, my primary doctor, versus I'm going to see my psychiatrist. So that's definitely one area where we're looking to reduce stigma. That's one of my advocacy. That's probably the one I've worked the most on.
Remember how like maybe 10 minutes ago, I said, oh, I have so many questions for you. So, the other question that I had in that moment was you mentioned how when you're providing counseling or therapy services and they're re experiencing traumatic events and how sometimes it's hard for you to even hear it. So, what do you do to take care of yourself as a psychiatrist?
Yeah, I think that's where, especially when you're a trainee, good mentorship with your therapy cases is important. Having someone that you can discuss the cases with and kind of work through that countertransference. Because countertransference works in strange ways. I mean, sometimes it can come out as like a deep empathy, and for the patient, sometimes it can come out as things like anger and frustration too, depending on what's going on within a case. But I think having a good therapy mentor is very, very important because these things have to be talked about. And sometimes somebody with a little bit more experience than you as a trainee can help guide you and help not only guide the therapy, but also work through some of those countertransference situations.
Because what we're seeing nowadays, not only are healthcare professionals and whatnot getting burnt out, but also therapists are experiencing burnout.
Hmm. Yeah, I mean, everybody, I think anybody that's working in this modern medical model is going to, at some point or another, experience some burnout. It's kind of impossible to not. because, again, of the demands that are kind of placed on you, whether it's as a physician, as a therapist, as a nurse. I think it goes all the way through the medical field in general. So we have to all definitely do the things for ourselves. So I don't want to, I know I said at the beginning, I feel like some of this is systemic issues, but I also don't want to undermine the utility of using things like your own outlets, whether that's physical exercise, things like healthy eating. Some people like mindfulness meditation. It all depends on the person. You can tailor it however it suits you, but doing those things to recharge your batteries, doing those things to step away from the job for a little bit. Another good one is technology breaks, because I think we're kind of attached to our cell phones at all times of the day. And if you're in medicine, there's nonstop text messages, emails, phone calls, and that in and of itself can also be a big source of burnout.
So I know that you are involved in things outside of direct patient care. I think you have a YouTube channel, you have a website.
Mhm.
If my listener wanted to learn more about what you're doing and how they can get in touch with you, how can they do that?
Yeah, so I think one of the best places to find me would be the website, and that's shrinksinsneakers.com. The name came from one of my best friends during training. She and I would always wear Chuck Taylor Converse sneakers to work as my work shoes, and we kind of got this idea that we're kind of the shrinks in sneakers because we were both always wearing sneakers to work. So it came up with that name. But yeah, that's a good place to find more information. On there you'll find links for YouTube channel and other social media outlets. I think I would direct anyone to the YouTube channel for the most content, because I've just found that to be a much easier way for me to create that takes less time than writing blog posts and things of that nature.
Okay. And do you have any final words for medical students, residents, anybody that you'd like to share before we end our recording together today?
Yeah, I think for medical students and even for undergrads, you have to definitely believe in your own capabilities, and you have to follow your goals and dreams, regardless of what other people are telling you. And even if you don't come from a prestigious background or don't understand all the intricacies of medical training, it's definitely still possible for you. And if you put that work in, you will find that there's a lot of payoff at the end of the journey.
Yeah. Who says a doc can't rap? DOCTORJB. The greatest doctor to ever touch the mic. The greatest podcast ever broadcasted or pre-recorded. Come learn some. Each one teach one. I'm done.